Okay, so I think that we can start.
All right, I will open the room. So we have 270 people now, but I think the number will rise.
Okay.
Okay, so no more chatting now, no more jokes anymore. I will open the webinar now, and everyone and real customers will come in.
Okay.
All right.
Perfect. Okay, so hello everyone. I don't know if you can hear me, or is everybody here and have good connection towards the webinar. I'm very happy to see you all here. We have around 300 attendees at the moment. So before I start this webinar, I would like to ask everybody to turn off your microphones in order for us and for the other attendees to allow us to have a good connection and good experience to everyone. My name is Dr. Marjan Stojanovski. Today I will be joined by Dr. Marjan Stojanovski as well in this webinar. We'll have the Q&A session at the end of the webinar, and this will be a recording, so in case you miss anything, you will have a chance to see it afterwards. I have to say, I'm really happy for so many people. And I will repeat once again each time we have new attendees to turn off their microphone, because as new people enter, it might provide bad experience for the other ones. As I said, my name is Dr. Marjan Stojanovski. I'm here joined by Dr. Marjan Stojanovski from Skopje, Macedonia. And without any further ado, I will start presenting my slides at the moment. I will also turn off the camera in order for all of you to have better experience. Okay, so what we will focus on this webinar, we will focus on the IMPLA system. We will focus on the IMPLA system, and we will not talk today about implant bed preparation. There will be a lot about soft tissue management and what everybody is interested now about the implantology and the COVID-19 pandemic. When I talk about the implant system, I will focus on the implant anatomy. I have to stop one moment because I see new and more new people joining in, which I have to repeat to turn off your microphones in order to not have echo. So about the implant system, I will talk about the connections, the product spectrum that we have in implants. I will talk a little bit about mini and hybrid implants, and then I will go a little bit deeper in the prosthetic solution. For those that are here and never heard of the IMPLA system, IMPLA is a implant system, a German implant system from a company called Schutz Dental, and we are very happy that it's one of the first, maybe the first German system created in 1963. The ideology, or what we stand for, is to provide the people with German quality, an implant system that can bring high performance and big versatility. I think that we achieved a big versatility because you have so many prosthetic solutions. We also stand for digital dentistry. Schutz Dental is a very good position company for digital dentistry, and we give everything for a fair price. The evolution of the implant system, so from 1963 till today, you can see how the implant body and the design has changed. So we started with something which is less aggressive when we had the Brannemark laws, where you have to wait before you load an implant. We had less aggressive threading, and we gradually continued towards the micro retention and the cylindrical implant, where we had more and more aggressive threading. This is our newest multi-unit system. It's a system which allows you to have good, stable prosthetic structures and avoid vital structures in the operating area, as well as sometimes avoid guided bone regeneration. Yeah, and the system, which I said stands for versatility. We have today the cylindrical implant as an all-around implant, and the micro-retention implant with a basic conical shape, perfect for cancellous bone. And another interesting thing about these two implants is that they are both available in cone connection and hex connection. Additionally, we have the mini and hybrid implants in this IMPLA system. About the anatomy, as you can see, our cylindrical implant is focused on aggressiveness. It has micro threading, this red line here, this red color here, and their threads on with a distance between another of 0.8 millimeters. It is a self-tapered implant, but what I have to say is that the threading is progressive. So the higher you go in the implant body, the threads are more and more aggressive, coming up to 0.4 millimeters. What this allows you to do, and what this helps you, is when you insert the implant in the implant cavity preparation, you feel very secure inserting it. And while you're inserting it, you can feel the bone quality, which is very helpful during implant procedures. As I said, the threading gets more and more progressive as you go toward the neck area of the implant. One more thing that I want to show you and I want to talk about is the implant surface. So this is sort of sort of an ARM image of the surface. It's a blasted and edge surface that improves also integration. Why I say it improves also integration, you can see how close it is to real bone tissue. And both of the implants have integrated platform switching. Now, our second implant, or the micro retention implant, is a very easy implant to grasp if you paid attention on the first thing that I said, so on the cylindrical implant, because basically they have almost the same platform switching. Both have very similar tapered thread in the cortical area or in the neck of the implant. You can see that the micro retention has this aggressive threading on top of the neck area, which allows you to fix and securely place the implant within that area where you have stronger bone, and they have the same surface structure. Now, the only thing that is different for the micro retention implant is the body of the implant. Now, This is less aggressive threading, which allows you to avoid necrosis because there's less pressure on the bone, as well as in the cortical bone area. It allows much smoother load distribution. If anybody is interested in the study or the test that we did around that, just write me here in the chat room and I will send you the study. It also is preferred design for upper jaw restorations with a poor bone quality, or if you have to do a sinus bone grafting and so on. And both of the implants are titanium grade 5 implants. The connection, as I said, we have two connections. The first one that I'm going to talk about is the cone connection. This connection has integrated platform switching, and based on the literature is one of the best connections you can have. It is sort of a hybrid connection because in the upper area of the abutment or at the neck of the implant is a cone-shaped connection, but at the end is secure with another hex. This allows us to have no micro gap, which is very advantageous for your restoration, and it provides almost no screw loosening or screw breakage. The hex connection comes with an optional platform switching. It's very predictable for during the movements. There's less than 1.5 degrees of movement, and it's a perfect positioning for if you do guided surgery or if you are more in the restoration part of the dentistry. Now, one thing that I will talk about is about this statement, no micro gap. Now, there's an additional advantage in the implants why we have almost no screw loosening. It's because our implants, both of our implants, the micro retention and the cylindrical, are retained with 6 retention screws. So what I mean by that is this area right here, if you can see my cursor. Wait, let me just turn the drawing on. So I'm talking about this here, this area right here, and on an area on a scan, you can see here how well the implant and the abutment are connected. And this is the area where most of the problems occur. So since the abutment is much better secured, you will have much better fitting. They function as almost a one piece. Here is another scan, and you can see there's almost no gap between the implant and the abutment due to the 6 retention screws. Now, when I talked about the inner hybrid connection, I said there's less than 1.5 degrees of movement. Now, I did some sort of animation here where you can see. What I mean by that is you should, if you see the yellow line, 1.5% is this movement right here. 1.5 degrees, excuse me, is this movement right here. Now, this is almost insignificant because in this presentation, it's more than 100 times larger. In reality, what you have is something like this. And that's why I say that within the mouth, this movement is insignificant. So we provided a perfect fitting for the abutment, the perfect connection for the abutment and the implant in both of our implants. Now, the mini and hybrid implants, these are one-piece implants, which are self-tapering implants. They're minimally invasive. They're mostly used in compromised regions, and you can immediately load them. Now, the first one, the mini bolt top, is used for more for removable prosthetics, but I see it more and more being used in one crown or bridge restorations. The second one, the mini cone top, is similar, but it has a different abutment area, different retention area. It's also minimally invasive. This one we see more and more being used for sort of a bar construction or one crown restorations, and an interim implant from titanium grade 5. This is sort of a provisional implant to use. Now, one thing that we did, and why I mention it here, is the IMPLA box. This is the older version of the implant box. Now, I will not go in detail explaining it. It might look complicated to some. It might look really easy to others. It's a color-coded system. But one thing that is interesting about it, you have 7 implant systems in one box. So you're ready for all the challenges that the implantology brings. Now, since we had people that preferably use other implants, we created a new box. This is the do-it-yourself box. Basically, if you decide to use one or just 2 implants from our portfolio, you can make your own type of box. And this is also interesting if you're like a traveling implantologist, if you own more than one dental practice, all you need is just one of these small boxes and you're ready to perform surgery. And as I said, you can change the box yourself any way you wish for. Now, for the options for the prosthetic treatment, as I said, Schutz Dental stands for restorations. We are very good positioned company in dental restoratives. And I want to talk about the options for prosthetic treatment. First of all, with both of the connections, with both of the 2-piece implants, we have closed tray impression. Also, we have open tray impression. They come in sort of small and large diameter. Sorry, not diameter. Height. We have smaller and larger depending on where your implant is placed. For this, you need a special tray, so you need an individual tray. We have also titanium abutments. All of our abutments are grade 5 titanium abutments, prefabricated with emergence profile. They're available in many angles, and we have a lot of different abutments for different type of gingiva. So if you have higher or lower, we also have you covered. Then I will just mention here the HLS abutments. This is the next one, are castable abutments, where the technician sort of models this blue area of the abutment, and at the end you have individual abutment where you can fit your crown. Also castable abutments. These are basically the same abutments, but the type of metal being used is different. We also have, if you're using CEREC in your dental office, we got you also covered. With the CEREC abutment, all you need to do is give the number written on the abutment, then model or design your cut abutment, and at the end you have individual abutment prepared in your CEREC machine. Also, we have other individual CAD/CAM abutments. The locator abutments that I mentioned, that I'm mentioning now, sorry, I didn't mention them before, are sort of abutments for removable prosthetics. These are, they have different types of additional parts to stabilize a removable denture. We also have ball anchors, which are also used for removable dentures. And more I see milled abutments, where we also got you covered as a preface abutments. If anybody is doing this type of work, you can just write me here or email me, and we will send you an STL file for your machine in order to prefabricate your abutments. We also have conus adapters, but I will not talk about them today because they were cannibalized by the next product, the multi-unit abutments that we have. And these are basically abutments that allow you to angulate your implants up to 30 degrees. And if you want more, you can use the ones that I mentioned before, the preface abutments to even angulate in 40 or 45 degrees. And this type of work is done in order to avoid vital structures such as the lower alveolar artery in this case, or to place implants and without or with very low guided bone regeneration. And yeah, they allow you to do removable and fixed restorations. So now I will play Marjan's pre-recording, since we had a lot of attendees. There was a pre-recording of this video. Marjan is here with us. He will answer all your questions at the end. But we pre-recorded his webinar in order to avoid any complication with the internet connection at this moment. If you have any problems, or if you have any questions, just write in the chat room.
Hello everybody, my name is Dr. Marjan Stojanovski. I'm a periodontist from Skopje, Macedonia. Since 2005, I've started to learn and improve my implantology skills in Schutz Dental Group and Valident Trade Implantology program. And in these 15 years, I have met many colleagues from all across the world. We share information, we share our experience, our knowledge, and improve ourselves. And this is a slide from Charité Institute in Berlin. Here we had a cadaver course, and we trained ourselves and did many interventions. This is a photo from my first lateral approach sinus lift. Since then we have done many more. Why did I choose IMPLA system? In the beginning we tried, we all tried many implantology systems, and I stick with IMPLA system because of the implant geometry. If you follow the drill protocol and biological rules, you will end up with a zero bone loss around your implant after implant loading. This is an X-ray from a patient, and you can see check the data. It is 2013. This sinus lift done, and on the controlled X-ray, we have a zero bone loss around our implant, and this is 2019 on this cemented crown. This was one of my first sinus lifts that I have done, and one of the reasons for this zero bone loss, in my opinion, is the premium connection between the implant and the abutment. As in this case, this was immediate implantation and after extraction, and this is 5 or 6 years after the implantation. This is the crown, and we have a zero bone loss, which is very important for me and my patients. It doesn't matter if you do immediate implantation after extraction. If you follow the rules, the biological principles, and the drilling protocol, you will end up with a zero bone loss. This is a X-ray after implantation, and this is 7 years after, and you can see this is a patient's mouth with not so good oral hygiene, and still we have a zero bone loss around our implant. So this is in my opinion, not only implant geometry, but the premium connection between the implant and the abutment. This is a case of a single crown placement in single implant. Lateral incisor in the maxilla, it is the most challenging for me situation because of it is working in the aesthetic zone, and this position is with the smallest bone volume in the maxilla, because the lateral incisor is the smallest tooth with the smallest root. And if we have a bone defects, this is very, very big challenge for every implantologist. And as you can see here, we are working in the regenerated bone. This is second stage, actually, what you see after guided bone regeneration. Situation was without any bone on the buccal side. You can see on this photo, this is a regenerated bone on the buccal side, and this is a implant placement of implant micro retention, 3.3 diameter. For me, from my experience, this is the only one choice for this position. This is the best implant for this position. A very elegant implant, very good diameter. It doesn't matter if you have a thicker crystally bone ridge or thinner. This is the only choice, in my opinion, for this situation. After this implantation, we did guided bone regeneration with beta TCP bone graft and collagen membrane. This is the post-op and implantation post-op, and as you can see here, we have a better volume and cemented crown for an aesthetic outcome for our patients. Now I'm going to share with you a video in the aesthetic zone. This is central incisor with a severe bone defect. You can see here there is a collapse on the buccal plate, severe defect and a very big challenge. CBCT shows practically there is no bone, as you can see here and here, and we raise a full thickness flap, and we started to prepare our implant bed preparation. This is a soft bone protocol, drilling protocol with when we have this type of situation with defects and a soft bone protocol, it is very important to do with the under preparation of the implant bed. This is the IMPLA cylindrical implant, number one choice for spongy bone with or without severe defects. This, when you implant this implant, it is with a very good primary stability, and you can see later on that there is no bone on the buccal plate, and we did here also guided bone regeneration, and with beta TCP bone and collagen membrane, and you will see CBCT and X-rays. This is the implantation. As you can see on the vestibular side, we have a grafted bone graft, and this is the temporary crown, and we have a papilla forming in. But after 3 months, we have a good emergence profile, no collapse of the tissues anymore. And this is the CBCT, shows regenerated bone ridge and we have again 0 bone loss, which is a very important if we want to have aesthetic outcome. And the central incisor, we must have a restoration with aesthetic outcome. This is how it looks in mouth. In my opinion, perfect restoration from starting point to finish point. It is a very, very good result. And another video of single implant placement of Schutz IMPLA cylindrical implants. We have hypodontia of the second premolar. We're missing the second premolar, and after the extraction of the tooth, we started to the implant bed preparation. And crystally, we have a thicker ridge, and this means that we can use a bigger diameter implant, but crystally we have a thicker ridge, and more apically there is no so thick ridge, because on this position we never had a root, and the bone is undermined, it's collapsing apically. So if we want to finish this intervention in a minimally invasive manner without raising the flap, we decide to go with 3.6 diameter of implant cylindrical implant with a premium primary stability, and this is how it was at the end. The X-ray, long, nice implants for a long-term stability. This is the cemented crown of this restoration. With this case, I want to share with you how can you tips and tricks. How can you secure your emergence profile immediately after implantation? We have a see here number 5 and number 6. We have a infected teeth with a fracture. You will see on the X-ray later on. The number 16. Some parts are luxating. With this hopeless teeth, we extract them, and we insert 2 IMPLA cylindrical implants, and we started with guided bone regeneration, beta TCP bone graft to correct the defects. And after this, I screw the abutment, and with the tip of a sterile glove, I isolate the bone graft. And in this, you see the slide in the center. Here we put flowable composite to fill the defects up to the gingival margin. At the third photo, you can see the individual healing abutment, and when we screw this individual implant abutment immediately, and we have this way we will preserve the volume, we will preserve the collapse of the soft tissue, and we are going to have a good perfect emergence profile. And the lower photos you can see gingival margin is the same as before extraction, and this way we will establish good biological width for long-term stability of our implants. This is the X-ray before and after. On the left X-ray you can see the fracture on the 15 and on the 16, and we have inflammation on the top of the roots apically. And when we have this situation, it's very important to go beyond this apical part, because of the endodontic treatment, the bone around the apex is dry and with a not so good blood supply. So it is good to go beyond this. And you can see on the right X-ray, we put with good length implants, and this is still a work in progress. But because of this pandemic, patient didn't came to finish the prosthetics, but this is after 3 months. It's already done. So I've checked this case. It's with the healing period went without any symptoms. So it is very, very nice case that we are going to document later. This is another case of a 6 implant placement. You can see the face here now with all individual abutments for a good emergence profile. And this is what we have on the left photo. You can see there is no collapse on the tissue. We kept the volume of the bone and of the soft tissue structure. You can see the collagen fibers are with the connection with the attached gingiva. This is and even we have a papilla forming in both photos, as you can see. Nice pink colors, and we didn't because the patient didn't give us a consent for guided bone regeneration and sinus lift on the other side. We have a cantilever solution for this multi-unit case that we finished. Later on, we have a video and that you can see, short video that you can see why we didn't put another implant here, but about that later on. And this is the rehabilitation of the patient. After this pandemic, we are going to work on the lower jaw. And with this case, starting with this case, I want to share one very important feature for me when I work with IMPLA implants. You can see on the right slide, above the implants, we have implant carriers, which are actually, they give us a lot of information during the implantation, and we can use them as a guides. You know, simplicity is geniality, and there are many implant systems that you need. There are many tools, and you can use those tools to correct yourself and to check yourself, and you check your implant position. When you work with Schutz implants, with IMPLA implants, this IMPLA implant carrier is your guide and gives you information about your position, about your future prosthetics. You can choose your abutments. It helps you a lot later on when you do the second stage, the prosthetics. So you are going to see many cases where I use this implant carriers as a guides, so you can go absolutely parallel without guide. You know, it is a little more. It is more expensive to work with guides. It's okay to work with guides, but this way, because I want to be 100% when I work my intervention, this is very useful tool. This implant carrier, and you will see when you use it how are going to be the results. When you remove this implant carrier, you can adjust your implant depth, whatever you like, whatever is needed for prosthetics. And this is also a big advantage of Schutz implants. There are many implant systems. When you remove the implant carrier, that's it. You cannot move the implant. So to choose your implant depth, it is a freedom and a 100% control of your work. Do you remember the case with the cantilever? This is the last implant that we put on the left side. See, beyond this implant, there is no bone for implant. So, and we didn't get consent from the patient to do guided bone regeneration or sinus lift and to do delayed implantation. So this is why we did this with a cantilever, which is okay. You can see in literature cantilevers and implants. You can check, and there are many situations that you can do and be safe with it. This is IMPLA micro retention, tilted, and you can just adjust the implant depth whatever you like, and you can see with the cantilever, not with the cantilever. You can see with the when you do tilted implants. With the implant carrier, how can you check the angulation that you have? And you can choose immediately, while you're doing this intervention, you can adjust the implant. It doesn't matter if it is a multi-unit or regular implant. You see, we have almost 20 degrees, so it is gives you very useful information. This is a case of a IMPLA cylindrical. You're going to see this implant placement, and I don't remove the implant carrier, and I'm going to put the other IMPLA cylindrical in this situation and very gently just correct my position and go absolutely parallel with the implants. So later on, me and my dental technician, we are going to have no problems with the prosthetics. This is going to be with the cantilever, but in the mesial side, because you can see here there is a mesially from this implant there is a big bone defect, and we choose to do this like this. Above here is the mental nerve, so this is safer for the patients. When you remove the implant carrier, you can adjust the implant depth, and you're 100% in control. So this is very important for me. This is a bigger case of 10 implants, and you're going to see this case with 10 implants. And we can go. Then you can go absolutely parallel. I'm going to pause here. We have to extract all teeth in the upper jaw because they are luxating and hopeless. We have to do sinus lift, many things, and you're going to see how did I choose to manage this case. I extracted all teeth, but I left the central incisors. They are hopeless. They are going to be extracted, but now during this implantation, they are very useful because I'm using them to guide myself for my implants. And I'm going to do simultaneous implant preparation. And you're going to see that we are going to go absolutely parallel in every direction, which is very important later on, not to face problems when you do your prosthetics. This is the first implant. Second implant, you can see the position of the implants, and the third implant on this side. They are absolutely parallel in every direction without guide. Simplicity is geniality. We can correct the implant depth and plan actually our implant depth. The other side with the sinus lift. Again, I don't remove the implant carrier because it is my guide. And this was before. I'm going to pause now and see. See the implants. There is a absolutely parallel implantation. We have done 10 implants, and we without guide, with the perfect position. This is with the restoration above it, and this is another case in the upper jaw. Here we are going. This is a case with a crestal sinus lift with the paste, and this is very interesting approach with a minimal invasive sinus lift. Again, parallel implantation. And we have is the titanium ceramic restoration, and this is the final outcome. Nice, elegant elevation of the Schneiderian membrane. Also, this case is a very demanding case. We have a collapse on the buccal plate, and when we check the X-ray, there is we have to do sinus lift. We have only 4.5 millimeters. And we decide for crystal sinus lift, minimally invasive approach. And this is actually how we elevate the sinus with the paste. Very safe way to do sinus lift. And this is the elevation. And above this, we just osteotomy to correct the diameter. And this is IMPLA cylindrical implant with a premium primary stability. And the ISQ value of this case shows rate 66, which is very good if we consider the fact that half of the implant is in the sinus, in the paste. And to correct the defect, collagen bone graft. And this is the corrected bone volume. You will see this, the corrected bone volume. So this is a good setup for aesthetic outcome. Later on, we have another video of a crystal sinus lift. Also D3 bone, very soft bone, and also collapsed buccal plate. We release full thickness flap and start with the soft bone protocol. IMPLA cylindrical, of course. And this is the, with the piezo unit, we gently penetrate the sinus floor, not to damage the Schneiderian membrane. And we inject the paste. And we have another IMPLA cylindrical put in. And collagen bone graft to correct the defect again. Suture. And you can see corrected volume, tissue volume. And this is a nice case with a very with the prosthetics that with good hygiene around it, because there is a good tissue around. Another video of again crystal sinus lift, but here we did palatal roll technique to improve the tissue volume on the vestibular side, and we did not mid-crystal incision but more palatal incision because of the palatal roll technique. Soft bone protocol again, and this is IMPLA cylindrical. And here we have another implant band preparation. I decided to put this implant here, not distally, because the bone was even softer and the implant was more collapsed. The sinus was more collapsed, so decide for this position. See, this is the actual penetration of the sinus wall. Valsalva test confirms there is no tear of the Schneiderian membrane. We inject the paste and started with the cylindrical implant. This is very interesting case because there is a literature of on a bicortical fixation of the implants in the posterior maxilla. The literature says that there is a better ISQ value when you have bicortical fixation, and this is this contributes to the outcome of the implants. And ISQ values shows 74 with the bicortical fixation, and lower rate on the second implant or without bicortical fixation. So whenever I have opportunity to go bicortical, I just do this, and you saw 67 rate, which is not also not so bad. Also, we flip the connective tissue on the vestibular side to have a this is the sinus lift, the X-ray, and you're going to see CBCT shows good elevation, and this is how it looks in the mouth. Mucogingival junction is very high, and there is no mucosal pool, and we have new attachment of the flipped keratinized tissue from the palatal side, and this is a good emergence profile, and it will be this way we are going to have stable long-term solution. Case with a sinus lift again, but this is a lateral approach. We used beta TCP bone graft here, and PRF membrane, IMPLA cylindrical placed. Again, good tissue around, attached gingiva on the vestibular side, and this is a very stable situation for our implants. Closed tray impression. The literature says that it is better to do open tray impression, and I really like both ways. But sometimes, if patient cannot open their mouth too much, and they do not cooperate, and I use closed tray impression with this implant system, which shoots implants, and I never had even a single problem with the closed tray impression. The final restoration. This is another case of a 3 IMPLA cylindrical placed with a sinus lift. With a sinus lift, and first we did sinus lift, and when we do preparation, when we insert implants in the premolar region, it is very important to have the proper distance between implants, not too close, but not too far one of each other, because if they are too far, it is this is going to later on the dental technician is going to make prosthetics with and these prosthetics, the teeth are going to be thicker, and the bridge is going to be a iatrogenic reason for infection. So it's very important to have a good, correct distance between them, not to have an implant collision, and to have a good distance to avoid any problems later on when we see there are about 2 or 3 millimeters in between. This is very thin bone ridge, and we have a good primary stability and also a zero bone loss on our implants. This is the situation before and after. Another video. We have many videos for you. This was a very big case of an infection and a collapsed sinus, very difficult task, and I invested 1 year in this case. Too much work. There was a large cystical defect, as you can see, major defect on the maxilla, beta-tricalcium phosphate bone graft, and above this I put collagen bone graft for tissue volume, because even before the treatment we I noticed that there is not attached gingiva of the vestibular side. This is the healing after the first phase. We have bone graft. It looks like we can do implant, but CCT shows that we have to do sinus lift also, a lot of work. And this is the first implant. We put 3.6, 11.5 IMPLA cylindrical, and on the second implant position, we first elevate the Schneiderian membrane. We fill the sinus cavity with beta TCP, and this is 4.5, 9.5 IMPLA cylindrical. I am inserting this implant in regenerated bone from the first intervention, and we have a good primary stability. This is very, very good result according if we have in mind the defect that was when we start the intervention. This is the implant position, good sinus lift, bone around the sinus, and you can see after 6 months there is no attached gingiva on the vestibular side. This can lead to problems and to bone loss after if we put in when we apply function. It's going to be with bone loss, so we need to have a keratinized tissue around our implants for long-term stability. We didn't get consent for free gingival graft, so we apically position the flap, and we have a nice keratinized tissue on the vestibular side, as you can see. Even better here. Closed ray impression, and we finish this case with the screw retained restoration metal ceramic. Video. Let me see what video is this. Wrist split. Again, in the lower, we are working in the mandible, a thin ridge, 3.2 diameters, and we split the ridge and put 2 IMPLA cylindrical implants. And we did very 2 months after this intervention, we opened the implants, and ISQ value was 80, and we did restoration. But we have poor tissue around our implants. We have attached on the vestibular side. We decide for a screw retained restoration, and this is why it's in the multi-unit and with a cantilever on the vestibular side, on the mesial side. Another video. Actually, this is one of my favorite cases when I used IMPLA Contop one-piece implants, narrow ridge. The plan for this patient was to do ridge split with the 2 implants and a 3-unit bridge, and we get consent from the patients for this. And on the day on the intervention, patient came and said, I really don't want to do this ridge split. I Googled this intervention. It looks painful. And can you do something else for me? And I said to the patient, because there is enough length for long implants, I told him that there is an option to do smaller diameter implants, not 3.6, but 3.0, but not 2 implants, to put 3 implants on a 3-unit bridge. So he said, oh, it's okay with him. We start the implant bed preparation to use the maximal length for safe approach close to the mandibular nerve. We use piezo because I wanted to use all the length I can use from this case. And we finished the drill protocol, and we insert the implants, implant on top. The slogan for these implants is small but mighty. Really, I agree 100% with this. 3 implants in absolute parallel implantation without guide. We're going to see the X-ray. It is the first implant looks like very close to the mandibular nerve, but CBCT shows that this implantation is safe. It's far from the mandibular nerve, from the mental nerve, and the volume around the implants shows, the CBCT shows that this is a very good, see the CBCT shows that this is a good choice here with the mental nerve. It looks like it is close, but it is not, it is safe. And there is enough bone on the lingual and the vestibular side, good implant placement and a good solution for this narrow ridge. This case, it is like 2 years now, and it's okay. I think it looks fine. This is a case of a all-on-4 with a bolt top. This is a solution on a budget. The patient wanted all-on-4, but with a denture. We have bone enough for more implants, for wider implants, but this was that we agreed with the patient. This was also done flapless. Nice length and good positioning. Ring attachments to connect with the denture. And this is the final solution. We have a video of a case also with a narrow ridge. Very old patient, 80 years of life experience, and we did all-on-4, but we use one-piece implants in this case, and you can see here the situation. I put some of my implants more palatal, with the palatal positioning, because of the undermined structure of the vestibular, of the buccal plate of the bone. I didn't want to penetrate the buccal plate, so you can see more palatal with these implants, this side. Yes, here. Crystally, we have a good rich width, but more apically, there is not so thick ridge. So this is why we have this position. Start with the lower jaw, and what is good with IMPLA cone top, you can. The advice is to work your prosthetics immediately with immediate loading. Implant bed preparation, stronger bone in the mandible always, and I did first the central implants, and then after that the lateral implants. This is the X-ray after closed tray impression and bar supported structure for additional support of the denture. CBCT shows good implantation. And these are the bar constructors for the composite restoration of this case. We have another all-on-4 case, but with IMPLA cylindrical. We have more bone volume in this case, and this was also done with immediate loading. First, implant the central implants, and then the lateral. IMPLA cylindrical with premium primary stability after implantation. And after removal of the implant carrier, we can adjust the implant depth. And this is also very important because this is a multi-unit case, and sometimes if the implant is not so deep, you're going to have problems with the prosthetics later on. So it's a very, very good feature. This is before and after implantation. Multi-units are inserted in, and we did here open tray impression with individual tray. We did with a monophase impression, and this is a key to check if the impression is okay, and this is the strong bar construction that is going to be a good support for this for later on for the restoration. There is a good oral hygiene with this bar construction. This is the final restoration. This case is a work in progress, but I wanted to share with you because we had many teeth to extract, all of them with infection or luxation and hopeless teeth. We did also guided bone regeneration and all-on-4. This is a closed tray impression. Also, we used the implant carriers as abutments in this case, and you can see when you're 100% in control of your intervention, even without guide, even if you have a lot of teeth to extract, you are going to do very palatal. You're going to go parallel with your implantation, and this is a good setup for a outcome later on. Nice. This is a temporary. These are the temporary teeth. On this case, you can see good gingiva shaping. There is a pink gingiva, and everything is okay. And later on, when we finish this case, we are going to present in video. And we come to the end of our presentation. And one of the headlines of this webinar was implantology and COVID-19 pandemic. Well, when we the term implantology doesn't refer only to setting implants. Big part of implantology is the care afterwards when the implants are inserted in, when we apply function. This is a big part of implantology, and we know that there are many peri-implantitis defects when we apply function, when there is a prosthetic buff implants. And during this pandemic, we have advice to avoid contact, which we have to do this as much as we can. We have to avoid the contact, but sometimes when there is a pain and swelling and infection, we have to treat our cases, the patients, to relieve their pain and swelling, to help them. And we cannot use high-speed turbine and generate aerosol or scalar, because this way there is a bigger chance for a cross infection. So we have to avoid generating aerosol. And in my opinion, when after this pandemic, we are going to face new protocols. We are going to face new, probably, rules and protocols that we have to follow. But until then, the safest way to treat infection and swelling and pain under implants is to use this product. It is called IMPLA. It is the content. It is a piperacillin tazobactam and hyaluronic acid. This is a very powerful combination that works 100%. And when you do peri-implantitis treatment, sometimes if there is acute pain or swelling, you have to inject this combination in the infected site, and in 1 or 2 days you are going to solve the pain, the swelling, and you're going to calm the infection. And my advice is to use this product just only to inject this if there is necessary need to have a contact. Then the safest way, in my opinion, is to inject IMPLA into the infected site. This way you are going to calm the infection, and when the pandemic ends, you can start your peri-implantitis treatment. And we have done many cases with this product, and this works 100%. This is a 2-implant cylindrical case of a 2-implant cylindrical bone level. Maybe they're too close, maybe they're not. But after 1 month, we have one implant failed, and the other implant is with severe bone defects. And this is how it looks in the mouth. We started the IMPLA protocol with decontamination of the root, the implant surface, and with the implantoplasty, and we use beta TCP bone graft for guided bone regeneration. And after 3 months, we have regenerated bone around our implant. So we save this implant, and because we owe the patient implant, we implanted another implant cylindrical. You can see around implant there are bone particles of the regenerated bone graft. And distally from the implant, there is an infected root fragment that we extracted. And maybe this was the reason for infection, or maybe not. And we finished this with this is after the implantation. And we finished this case with rounds that were screw retained restoration. So my advice during this COVID-19 pandemic is, if we have to avoid contact, but when we must have a contact with our patient and with this type of problems, just inject the IMPLA in the infected site, which is around 20 seconds, very fast. You are going to finish. You are going to prescribe antibiotics, and later, when this pandemic ends, you can start the IMPLA protocol and with the peri-implantitis treatment and solve this patient problem. I come to the end of my presentation. Thank you for your attention. Stay home, stay safe, stay healthy, and see you on our next cadaver course in Istanbul, Turkey. Best regards to everybody. On our next cadaver course in Istanbul, Turkey. Best regards to everybody.
Okay, so Marjan, are you there? Can you hear me? Hello? Hello? So, during the webinar, I hope we managed to answer all of your questions. Hello? I hope we managed to answer all of your questions that you had. I know you had many questions during the webinar. We are trying to connect now. Hello, Marjan.
Yes, I can hear you. Can you hear me?
Yes, I can hear you as well. I see you're wearing the mask. So during the webinar, we had a lot of questions. The first question, of course, was which area of the bone do you prefer to do the tissue harvest?
From which area I prefer to do tissue harvesting?
Yeah.
Well, when we raise a flap, we can always, if there is enough tissue volume, flip from a palatal side to vestibular side or wherever is needed, rotate pedicle flaps. We can do always this. If there is not enough tissue, we can use from the tuber maxilla, from the upper jaw, and we can these are the most common places that are really painless. We can take if there is need of a free gingival graft from the palatal side also. After we suture this side, we can do many things with our with the soft tissue. Actually, we are obligated. In my luck during this implantology practice was that I had very poor tissue quality with my patients. So almost on every case, I did some soft tissue augmentation before implantology and the same act, or after the implantology.
Yeah. Thank you. The second question, of course, it comes during the current, because of the current situation in COVID-19 pandemic. So regarding that, first of all, which patients do you accept now during the COVID-19 pandemic, and what are the procedures that you choose to do and how you go with it? Could you a little bit explain more about that?
Well, if we talk about implantology in dentistry, this is an elective surgery, and the advice is to delay all elective surgeries during COVID pandemic because of the chance for cross infection. And but there are many implants inserted in. And 3 years now, I'm a peri-implantitis therapist, so I do many peri-implantitis cases. And during this COVID pandemic, we are not able to perform the peri-implantitis treatment because of the aerosol that we generate during this procedure. But only if we must do contact, we choose to work on urgent patients with swelling, with infection, with pain, and we just inject this antibiotic with hyaluronic acid, which it works very good, and it will count down every infection. So we are going to help the patient, maybe one time, maybe sometime is needed two visits, but that's it. This is a short intervention. In 20 seconds, maybe you're going to finish, and you're going to help the patient.
Okay. Well, we have many questions. We will give you all of the answers via email. But the last question that I want to ask you that I chose is, which implant do you prefer to use in a poor bone quality?
In a poor bone quality, I never hesitate. I use only IMPLA cylindrical implants because of the premium of the primary stability. Very reliable implant. I get very often good ISQ values after intervention and much better ISQ values before loading. So IMPLA cylindrical implants are, especially if we have a spongy bone with severe defects, I use IMPLA cylindrical implants. Also micro retention.
Okay.
Perfect.
Okay.
I see questions here. After bone augmented, how long time should be waiting to do second stage? Well, it depends. If we augment in the sinus, we have to wait 5 or 6 months. We can always check with the eyes with the ISQ value and early start with the implant loading if there is a good ISQ value. Sometimes augmentation is only to correct the defect, but doesn't contribute to the primary stability. We have enough bone and enough good primary stability, good fixation of the implant, good primary stability, and then we wait less, like 3 months, and do the prosthetics. What paste was that used for sinus lift? This is a beta tricalcium phosphate paste, very interesting product that allows you to work in a minimally invasive manner, very easy, very fast sinus lift, and in no time you can finish the intervention. This way you have done sinus lift with a less exposure and less exposure of the aseptic air of the patients, which means less swelling, less pain, and good healing time after intervention. There is another question: do we may to use the IMPLA for alveolitis? Yes, we can. We all know the anti-inflammatory effects of the hyaluronic acid, and piperacillin tazobactam is very, very strong antibiotic and works. This combination works 100% when we use this. We can use also IMPLA Protect for teeth implants. We can use Gilside. Basically, these are products that are maintenance around implants and teeth.
Okay. Well, I know you have a lot of questions. You can post them here or email us afterwards. Now, I would like to thank Dr. Marjan Stojanovski and thank you all on behalf of Schutz Dental for attending this webinar. You will get feedback afterwards. Thank you, Dr. Marjan, for this wonderful presentation. We have a lot more to come in the current period, so we will have a lot more webinars. So please make sure to check out or subscribe to our Facebook page or to our newsletter. Stay home and stay safe. Wish you all the best.
Best regards. Bye.